Welcome, everybody. We're going to give people just a few minutes to get signed in, but feel free to go ahead and drop where you're located in the chat. I'm in Columbus, Ohio.
And I'm in the Indianapolis area.
And I'm coming in from Rhode Island.
As people are joining, feel free to drop in the chat where you're coming from. We're just going to give everybody a little bit of time to get online. Rachel, I see your question in the chat, and we're going to talk a little bit about that as we talk through what ABA therapy is. Hi, folks. If you're just joining us, feel free to drop your location in the chat so we can see where everybody's coming from. We'll give everybody about another minute and then we'll get started.
It's so nice to see people from all over Arizona, Ohio, Massachusetts, New Jersey. Fantastic. My
Yeah,
name's Natalie Scott. I'm a speech language pathologist with Bierman Autism Centers, and I am from the Indianapolis area.
I think we should probably just go ahead and get started. So let's do our official introductions now. We'll try to give you a little bit of very brief background about ourselves because I don't want this to be about us. I want it to be about answering all of your questions. So my name is Elizabeth Henry. I'm a regional clinical director here at Bierman, and I am a board certified behavior analyst. So that means that my specialty is in ABA. And I've been working in this field for 25 years now. And when I started in the field, I was very fortunate to start at a children's hospital that had occupational therapy and speech therapy alongside ABA. And so I feel very passionately about us collaborating so we can best meet the needs of your children. Natalie, I'll pass it over to you so you can introduce yourself.
Sure. My name is Natalie Scott. I'm the director of speech therapy with Bierman Autism Centers. I also keep a caseload in Avon, Indiana, and assist with some teletherapy in the Fort Wayne, Indiana area. And I have been with Bierman for the past year, collaborating with our BCBAs, our behavioral therapists, occupational therapists. Prior to that, I worked in the birth to 3 population and also did some collaborating with some in-home ABA.
Hi, everyone. My name is Maeve London. I'm the Director of Occupational Therapy Services here at Bierman. I am an occupational therapist, but my background is also in education in a teaching capacity, and I've also worked for a few years as an RBT, so working within the ABA field as well. So I really value my background working in homes and schools and clinics because I feel like it's given me a really wonderful opportunity to collaborate with other professionals and get some insight into how they do what they do, and it's really enhanced my collaborative relationships moving forward throughout my career. So I'm very excited to talk about that today.
All right, everybody, let's get rolling into all this content here. Oh no. Now our technical difficulty has arisen. It will not let me advance. There we go. All right, just had to use a different way. So we want this presentation to be as interactive as possible. I love to see that you guys are already using the chat. There's also a Q&A button at the bottom of your screen. Please feel free to drop questions in the Q&A section, and Maeve has graciously agreed to monitor that throughout the presentation. We have a good amount of content prepared for you guys, but this is really meant to meet your needs. So if we skip some slides or something because we're answering your questions, then I feel like that will be a successful presentation. Because it's all about you guys as the caregivers. All right, let's jump into the rest of this. So today we're going to give you an overview of what applied behavior analysis is, an overview of speech therapy, and an overview of occupational therapy. And then we're going to discuss the collaboration amongst us as providers. As we were preparing for this presentation, we started having a lot of conversations about the way we interact with each other and kind of thought, this is the part that families need to see. They need to see the value in having all of these professionals working together to create treatment plans and goals for your children so that we can advance their skills. So that said, I'm going to jump into the overview of ABA. So behavior analysis is a science that's dedicated to understanding how and why humans behave. So when we're talking about behavior, that's really anything a living organism does. And that can be you, me, your children. It also relates to your boss at work, the dog down the street. And when we talk about applied behavior analysis, we're talking about it from the standpoint of making socially significant changes in human behavior. That's what the applied part is referring to. So the only way to do that is to learn how and why someone behaves the way they do. So we always say there's a why behind every behavior that anyone engages in. And then once we figured out kind of that why, then we take a look at the environment and see how we can work with the environment to improve that behavior in a socially significant way. Socially significant just means teaching skills that will improve the overall life experience for someone. So an example might be learning how to follow safety commands and directions in the community. So the child can go and enjoy more community experiences. So they're not limited to staying at home or in a restricted environment. Or it might be as simple as learning how to ask for things that they want or need, to have better relationships with people around them. So, in kind of answer to one of the questions that came in at the beginning when we were all kind of getting settled, ABA is definitely used to decrease behaviors that might restrict a child's access to things. We certainly want them to be able to go out into their community, but it's also about skill building. We're kind of looking at the whole child and looking at all of the behaviors that they engage in that create that human being that you live with and you love, and then seeing how we can help them develop new skills or change some things that they're doing so that they can have a full and robust life. On the next slide, I'm going to show you some of what we might target. If I can get it to change again. There we go. So in ABA, we're going to be looking at things like communication. So that's where there's a lot of overlap with the things that I'll be doing and Natalie's doing. Also social behavior. So there's overlap between kind of the things that I might focus on in my clinical work and also what Maeve and Natalie would focus on. Toilet training is a big thing that parents come to us about. Play behavior, again, a lot of overlap with both Maeve and Natalie. Independent skills, again, those are things that both Maeve and Natalie are focused on too. And tolerating non-preferred tasks. So kind of like building up flexibility in your children. So I think you kind of are starting to get the idea that most of the things that I might want to address as a clinician and that you as parents and caregivers might want us to focus on are things that all three of us are concerned with. And all three of us are trying to use our clinical expertise to teach them in the most effective way for your child. I keep losing control of my advance. Let me click here. There we go. All right, I'll pass it over to Natalie now, and she can start to tell you about speech therapy services.
Hi, everybody. Okay, so what is speech therapy? Well, it's not just talking. In order to talk, there are many cognitive or thinking processes and pre-linguistic or pre-talking milestones that need to be mastered before talking occurs. And that is why we don't typically hear words out of learners, children, babies, until they're at or just over their first birthday, because there are all these little skills that they're working towards in order to be a talker. And that is also why we don't typically see 4 or 5 word sentences until that learner is approximately 3, maybe 2.5 to 3 years old. So speech therapy is not just talking, which is why initially when your child may be getting started in speech therapy, they may be working on some other activities than just talking. But before they get started in the therapy aspect, the speech language pathologists are providers that complete a variety of speech, language, and swallowing assessments in order to get an idea of where that child is at. In order so that we can diagnose and treat a variety of communication, language, speech, and or swallowing disorders. So, based upon the assessments completed and the information that we have gathered in those assessments, then we determine what areas of treatment may need to be targeted. Areas of treatment may include speech disorders, and speech disorders include the possible reasons why a child is either not talking or the reason why others are having difficulty understanding what the child is saying. Language disorders include receptive language skills, or those are those areas, or the reason. Receptive language is all about understanding what other people are telling us. So, for instance, if your child were to have a receptive language disorder, that might be the reason why they're having difficulty following through with directions and why they may not be doing the things you're asking them to do, such as like, go get your shoes or get your coat, wait at the door. If they're not quite sure what their shoes are or their coat or what that word wait means, then they're going to have difficulty following through on those directions. Language disorders can also include expressive language skills or the ability to tell someone what they want, which is why there is so much collaboration with ABA, because communication is such a huge piece of our personality and us. Without vocabulary skills, that child is not able to tell people what they want to eat or that they're even hungry. So you can imagine if you're hungry and you don't have the words or the gestures or any way to communicate that you're hungry, then that you're going to get very frustrated, and that may definitely increase the risk of you having a behavior or acting out because you're just so extremely frustrated and you are hangry. Um, with pragmatic or social skills, those can be sometimes a higher level communication skill, not always, but sometimes it's a bit higher level, and that allows children to act in socially appropriate ways, such as, that child learning to make friends, learning that it's okay to share their toys, and sharing those toys without hitting or biting others. A huge piece of pragmatic or social skills is that we learn to wait when we're told to wait, and we don't continue to cry, fuss, or tantrum when we don't automatically or immediately get what we want. AAC, or augmentative and alternative communication, that allows children to have a way to communicate their wants and needs when they may be having some complex communication difficulties. Um, Complex communication difficulties may take years to treat in speech therapy, but it isn't fair to ask that child or to ask family members to wait years before the child is able to become a functional communicator. So AAC allows the child to communicate in a different way other than words that may come out of their mouth, because that using a device or a gesture or pictures may be what is easier for that child at this time. The child may go on to continue to use AAC for their whole life, or it may just be for a period of time while they continue to work on traditional verbal speech skills. And lastly, swallowing disorders refers to the difficulty with swallowing saliva, swallowing food safely due to motor or sensory difficulties, and also swallowing drink safely with appropriate motor and sensory skills. The muscles involved in swallowing, swallowing is a very complex activity. And if those muscles involved in swallowing won't work well, or if they're weak, or if the child doesn't feel the texture of the food in order to initiate a swallow, then that child may not feel comfortable eating, and or they may not have the endurance to eat an entire meal. They could be at risk of choking, malnutrition, and or getting aspiration pneumonia. So you can see that all 5 of these areas are very complex and also very important to be assessed in speech therapy in order to determine what your child's needs may be. Elizabeth?
I'm trying.
Okay, no,
Go.
that is absolutely fine. Thank you.
Yep.
So I broke those areas down a little bit more. In regards to swallowing or eating, there are 3 phases of the swallowing process. That is the motor phase, or what's happening in the mouth. Secondly, that is the laryngeal phase, or what's happening in the throat. Hopefully what is happening is your voice box or that larynx is elevating so that that food and drink does not enter the airway, and it instead goes down the esophagus. And the esophagus is then that 3rd phase of the swallow. And then we want that food to stay in the esophagus and let gravity bring it down into the stomach, and then stay in the stomach and no reflux or no backup. And with swallowing and eating, it's not just a motor control, there is a huge sensory component, or whether or not that child's musculature can feel what is happening with the swallow. If the food and liquid goes down the wrong way, does that child feel it and initiate a swallow or not? Does the child like the texture of the food in their mouth or not? Obviously, that's a huge component and can lead to some malnutrition issues if they're not having tolerating a wide variety of textures. Speech. Oftentimes we think of speech and just, again, talking. That child may be having difficulty with some specific sounds, maybe an S, maybe an R, maybe an L, and that would be considered to be an articulation disorder. If that child is having difficulty with what we call patterns of sounds, that is called a phonological disorder. And those can get a little bit tricky. And it's typically our children with a phonological disorder that we really struggle with to understand what they're saying. They may be just not even trying to say the initial sounds in a word or the ending sounds in a word. So obviously, if the child is trying to say the word cup, and they're just saying up, and that person thinks, oh, they want picked up, and really the child is thirsty. When you go to pick them up, they may be super frustrated and try to throw a fit because they really wanted the drink. Dysarthria is a motor weakness, and that could be the reason why it's difficult to understand them. Perhaps their speech sounds sluggish. And then lastly, a muscle motor planning difficulty. And research has told us that there is a high incidence of children who are diagnosed with autism that may have also what is known as child apraxia of speech, or knowing what they want to say, and that message from the brain somehow hits a brick wall, and it may look like the child is getting ready to say, mom, but instead we just see, like perhaps they were going to say something and then nothing comes out. Again, those language disorders are broken down into receptive language and expressive language, whether or not they're understanding what people are saying so that they can follow directions, so that they can point to what is being asked of them to point to, and understanding those WH questions, which are who, what, where, when. And then expressive language is being able to utilize those vocabulary skills in order to get the words out that we want. For instance, so that the child can tell you apple, apple when they want an apple. And also, if you ask them a simple yes, no question like, oh, the pen? Like, you want the pen? They're able to nod their head either yes or no, or verbally tell you yes or no, so that they can verbally tell you what they want. Again, social language is a big piece of the communication puzzle, because obviously if the child is having difficulty attending to other people or attending to tasks, then it's going to have a significant impact in their communication skills. So as speech language pathologists, sometimes we may need to back things up a bit and work on what we call pre-language or pre-linguistic skills, so that that child is attending to different activities. Also with social language is greeting and being able to comment, and then also appropriately protesting, because it is such a huge part of our quality of life to be able to say, I don't like that, or I don't want that. And we want that child to be able to protest and tell us what they do and don't want. And then I had talked earlier about augmentative and alternative communication. That is either use
Natalie,
gestures.
I
Oh,
just want to tell you, while you're getting into the AAC, there is a comment that's asking about how speech therapy can help with children who are nonverbal. So I thought that would be perfect for you to throw in as you're talking about AAC.
wonderful, wonderful. Both myself and our other speech language pathologists do so much work every day working with various learners that may need AAC, or we work on augmentative or alternative communication. Um, we do see our autistic learners, some of them, where they are nonverbal. So therefore, oftentimes we may work with a company, an outside company, to see about what appropriate speech generated communication device may work for that child. And again, that's a huge collaboration piece where Elizabeth and I and Maeve, we would all be collaborating together in order to figure out, typically it's the speech language pathologist that has an idea of what device may work best, but then we are getting that child to utilize that device across various areas in order to communicate. And we'll talk a bit more about augmentative and alternative communication a little later on in the presentation. Lastly, oh, that's okay, Elizabeth, with that speech generated device or a picture communication book, that child may be using that augmentative, the AAC device for throughout their lifetime, or for a short period of time while we're working on expanding their communication needs. Very quickly, we just at Bierman, we're all about a team effort. So when that speech language pathologist is evaluating your child, not necessarily a Bierman SLP, but they should be finding out what the child's strengths are, where there are challenges that that child is meeting, what challenges you are encountering, or what you feel as that child's parent is going really well at home. All of those pieces of information are very important as the SLP is being that investigator, getting to know your child and what may be wrong and how to come up with an individualized communication plan. The child should be given a wide variety of assessments. Again, if it's a speech disorder, is it an articulation problem? Is there some sort of motor planning problem, which is impacting why the words aren't coming out of that child's mouth? And it's super important that in speech therapy, we're just not trying to put a Band-Aid on for short-term benefits, that we are really truly addressing the root of the problem. Because again, communication is such a huge, huge part of that child's life. With that information, it's super important that the SLP is taking a look at what that child is able to do, where their strengths are, and then start working from that point on and upwards. Obviously, we want, if the child is nonverbal, like the question was asked, we're not going to start up here where we're working on trying to get that child to elicit words. There are some steps that need to come ahead of actually getting those words out. Okay. And then lastly, don't be afraid to make an appointment or let the SLP know that, hey, I'd like to come and observe and participate in speech treatment, because we know that that child's outcomes are going to be so much better if the therapy isn't just isolated to the therapy room or isolated to occur just with the speech language pathologist. Okay. Yeah, I see that question about American Sign Language. If it's okay, we will save that to the end. Um, um, we
We can
do,
go ahead and, yeah, we can go ahead and let Maeve do her overview and then jump back to that one. Okay, because there's another question about whether or not we should do ABA or OT for social interactions and emotional regulation. So I want Maeve to be able to do her spiel, and then we'll take a question break, answer any pertinent questions, and then go back to the slides. Does that sound good, you guys? All right,
does.
perfect. Perfect.
I'm looking at this slide where it says common goals, speech and ABA, and noticing another person. For speech, that would be related to a social pragmatic goal, and or again, with social pragmatic language, attending to others, noticing them.
All right. Thank you for all that information. I'm gonna switch over to Maeve now and let her give us her overview of occupational therapy services.
Excellent. Well, when I'm talking about occupational therapy, the first thing I want to make sure I'm doing is, defining some terms, right? Because we didn't necessarily pick a self-evident name when we decided on occupational therapy. So, when we're talking about pediatric occupational therapy, I promise that we're not sending children out with little hard hats out into the workforce where, occupation for us is any activity that occupies your time. So for OTs, when a diagnosis or an injury or an acute event, prevents an individual from meaningfully engaging in those daily occupations. And those can be things that you need to do, you want to do, or you are expected to do, throughout your day. An occupational therapist is there to help facilitate access to those activities. So occupational therapists work across the lifespan. So they are there in neonatal units, working with babies on their baby occupations all the way up to, a hospice environment. And what we rely on is, an anatomical, physiological, and a neurological background. So we're, a little bit more of we're a biomedical model that uses those three disciplines to kind of pull in to inform our approach when we are designing our interventions. So when we are talking about pediatrics, we are talking about what children do. So how do they occupy their time? So Elizabeth, if you want to pop to the next one, we can chat a little bit about major pediatric occupations. So the first one that springs to mind, as it should, would be play. So children learn an enormous amount through their play, and they also develop an enormous amount of their skill sets through play. So it will be, their fine motor development, their gross motor development, and their visual motor development very often are facilitated through play. And that's why very often if you see, an occupational therapist at work, a lot of what they do when they're targeting those skills are facilitated through play activities. School readiness is another area in which occupational therapists spend a lot of their time. So that is, handwriting, grasping utensils, writing utensils, scissor skills, visual motor skills, dual attending. So can they visually attend to a whiteboard and then shift their visuals to attend to the work that's at their table? Can they sit properly in their chair, or do they engage in a lot of compensatory strategies where they're leaning over or falling out of their chair? What's their postural control in a seat, and are they set up for success in their environment while they're seated so that they can attend to the other things that are going on in their classroom? Can they screen out or habituate to different sensory stimuli? So if they have a difficulty with auditory processing, for example, and someone is tapping their foot next to them at the table and they're trying to attend to their teacher, how effectively can they moderate or modulate or habituate to that other stimuli in their environment to maintain attending to the thing that they're trying to attend to? Eating is another thing that our children, spend a lot of time doing, and informs a lot of their day. So within that, eating, we'll talk about feeding more because it is such a quintessential kind of example of how we all work together. And, from an occupational therapist perspective, again, we'd be looking at that postural control. Are they seated in a safe position? Are they able to manage and manipulate materials, their bowls, their utensils? And are they able to tolerate different sensory information that they're getting from their food while they are consuming it? And last but not least, children are expected to participate in hygiene activities. So brushing their teeth, tolerating getting their hair brushed, tolerating the feeling of water during bath time, tolerating getting dressed into their pajamas and, how that might feel for them versus, their jeans when they go to school. So ADL, so activities of daily living, so that dressing and that hygiene is something that occupational therapists will look at during our interventions. So when we talk about, obviously those are the occupations, right? Those are the big picture occupations. So, what is it that we're doing on a daily basis when we are in session and working with a child? If we're taking buttoning, for example, so we talked about that activity of daily living of dressing, and a component of that would be the fine motor skills. So can that child isolate their fingertips so that they can grab onto that button? Can that child sequence the activity of grabbing the button and putting it through the loop? Can they orient their clothing while they are dressing? Can they visually attend to that activity? Gross motor is a very important part of what we do. So when you look at the development of, children, it goes gross motor, fine motor, gross motor, fine motor. So we have to have that gross motor piece before we get that fine motor engagement. So that's why you see, babies when they're 4 months, 6 months, 9 months, 12 months old. A lot of what we're focusing on is, are they rolling? Are they holding their head up? Are they sitting independently? Because until we get that independent sitting, well, we wouldn't necessarily be looking at eating, right? Which is, a major human occupation. Before we get them grasping at a rattle, we're not going to ask them to write their name. So we have to have those big gross motor movements, because once we get those mastered, then that allows the fine motor muscles to do their important work. So very often, you might see someone, an occupational therapist, running around a gym, and someone says, well, what are you working on right now? And I might say handwriting, right? Because until I get those big motor muscles working, I'm not necessarily going to be able to make the gains I want to see in fine motor. And last but not least, we have the visual motor piece. And so that is, an individual's ability to see something. So visually take that information in, process it, and then have a motor output. So, colloquially, we could probably call this, hand-eye coordination. So, ability to, isolate the puzzle piece and then manipulate it into the puzzle. It could also be, tracking a ball towards you and catching that ball. Visual motor is also going to look like, scanning, like Natalie had said, if someone said, hey, can you grab your sock? And the sock is partially under the bed and partially visible. Well, can that person visually scan, identify that object, and know that even though they can only see part of it, they can imagine the entire object and know that that is my sock? Or do they see half the sock and then they don't identify it as a sock because the full image is not available to them? So there's a lot that goes into visual motor and visual perception that occupational therapists will look at to make sure that they can be successful, because they might have the receptive language to, hey, go get your sock. But if they don't have the visual perceptual of identifying a sock in various environments, partially or fully available, then they may not be successful in that activity, even though they know what the expectation is. So occupational therapists will do a lot of work to make sure that the motor components are functioning as optimally as we can, so that they can be successful in a number of their in their daily activities. So common goals that we see with OT and ABA, we have it's such a luxury to work at Bierman because we have all these opportunities to overlap. And ABA has such phenomenal opportunities to work very intensely with our kids, up to 35 to 40 hours per week. So I really, rely on my, ABA therapist to be able to kind of have these great collaborative conversations, and then they get all this opportunity to practice, right? So a lot of what they'll be working on is gross motor imitation. So can they do those big motor planning movements? Can they visually see what an individual is doing and then copy that action back to them? Fine motor imitation, we do a lot of modeling. And so we work on developmentally what is going to be appropriate for us to be targeting. And so OTs have that kind of developmental background of what is, gross motor and fine motor over a lifetime. And so we work a lot on what targets would be appropriate. And then ABA does a lot of that implementation and working on getting, the behaviors to a point that they can participate in those tasks. And then, of course, we'll dig in further as we go for play skills and feeding and those daily living skills.
All right, I think this is probably a good place to take a break and get back to some of those questions. So the first one, let me get back to it. The first one in the chat that I can see is it better for a child to have ABA or OT when it comes to social interactions and emotional regulation? Maeve, do you want to start with that, or do you want me to jump in?
Oh, I love this. They're just pitting us against each other right off the bat. So my answer is, of course, both. We both have, such wonderful opportunities to target these skills. I can say, personally, from an occupational therapist perspective, what I'd be looking at is, an OT can look at something like a sensory profile, right? So what sensory information can perhaps a child be seeking or avoiding in their environment? And then how is that impacting their regulation? And so what strategies, one, we have standardized assessments that can identify some of those things. And then once we have that information, we can all work together on, okay, how can we modify the environment or give them strategies to help, tolerate and better regulate that input. So for example, if I run the sensory profile standardized assessment and I see that there's some auditory aversion or auditory avoidant things that we might see, a child has a hard time in a restaurant and they're covering their ears, or they're on the playground and maybe they're having a difficulty, anytime a peer comes around them that's yelling and having fun, right? So maybe headphones might be useful in that environment. So I know from an OT perspective, we'd be looking at, how are they filtering that sensory information and what strategies can we give them to kind of modify or better tolerate that information? And Elizabeth, I'll kick it to you for kind of how ABA approaches these things.
Yeah, so I think I love everything that Maeve just said because, when we're thinking about children who are struggling with some of those social skills, my focus is on what skill are they missing and how can I teach it? But from Maeve's perspective, there are going to be times when a child is not ready to learn the skills that I have to teach because there's too many competing factors in their environment. And so without her expertise, I might miss some of those things. So it's really, really valuable for me to have input from someone like her to help me figure out how to get the child ready to receive the skill-based teaching that I can do. But as far as like which one is better, I don't think one is better than another. I think it is really dependent upon what your individual child needs. Because all of the kids that we see are different. They're all coming to us with different skill profiles. And some of them might be able to just benefit from working with me. Some of them might be able to benefit from just working with Maeve. Some of them might be able to benefit from just working with Natalie. Some of them might need all three of us or a combination. So I think also what Maeve was saying too about kind of evaluating what is happening with each child through assessment is going to be the best way for us to figure out who your child should see. And I think, I know that that's a tough thing for parents to get access to in a lot of situations. I know that there are not enough professionals out there for you to see, but I would, if you're seeing us, please, request from whoever you're in contact with, your BCBA, your CD, your PM, your SLP, your OT, let them know you're concerned about the skill and that you want some help with it. And if you're not seeing us, please start with the providers that you are seeing, whether it's your school or private providers, and ask what they think about collaboration with other professionals too. And then we had a question about, is ASL a viable solution for nonverbal children? So, Natalie, I know you wanted to say some things about that, so I'll let you jump in there.
Sorry, I was muted. So ASL stands for American Sign Language. And so American Sign Language is utilized very often within the deaf community. And we do use in speech therapy and occupational therapy and perhaps ABA some different signs. Sometimes there are more, sometimes it's come here. So sometimes we do use gestures or signs, not necessarily American Sign Language with our autistic learners. But that is if the child is nonverbal, depending upon the results of a speech and language assessment, perhaps gestures may be a way to start some communication.
Maeve, do you want to jump into the question, the Q&A section, and see if there's anything we should address right now?
Yes. So there was a few questions, Natalie, relating to SLPs, and one would be, would speech therapy be able to help with volume control and tone?
Actually, yes. So volume control and tone. Um, my mind is already thinking without having assessed the child. Um, it may be a difficult concept based upon social communication or pragmatic skills. It could be an issue due to a voice difficulty, um, breath support, if there is any muscle weakness, and that may cause the child to either talk in a monotone or perhaps have a very quiet voice or breathy voice. If the issue is quiet or breathiness, perhaps there is a motor planning component, and they've started getting those pieces together to be able to use the vocal cords, to be able to manipulate the tongue to get various sounds, but perhaps they're just fine tuning it to be able to, speak with intent. But right now it's a new skill concept for them, so they may be a little hesitant. I myself oftentimes will like, words give you power. And I love it when our learners learn that like, hey, yay. And they're able to um, communicate with a wide variety of voice inflection. So without knowing your child, it's a little bit, hopefully I've gotten on the right track.
Thank you for
Any other
that.
questions?
The question that we had, what is a great question, and it is that my child has different speech and OT providers. Any suggestions on how to get them to communicate and work together? So this is, again, why, Bierman is, I say it's such a luxury to work here, because we do carve out that time to sit down every, on a weekly, monthly basis, and we're in the same halls, working in the same environment, and so it really has that cohesive collaboration opportunities. Barriers pop up when we are going from place to place, and that's not, I think, the intention of any provider, right? They want to provide as holistic therapy as possible, but there are just practical barriers that pop up when you are working in different environments. I think the one thing that kind of jumps out to me is one, knowing that you can be that pivot point for that communication. And so do you have a HIPAA in place for both so that they can communicate? Do we have all the documentation that we need? Because they wouldn't be allowed to even have that conversation unless you had allowed permission for that to occur. So, making sure that when you are starting with someone, here's my HIPAA, and making them aware, sometimes I wouldn't necessarily know as a provider that they do have another provider in a different discipline. I should have that information. I should be getting that from, their medical, and that's a question that I need to be asking. But, ensuring that they are aware that other providers exist, the cadence at which they're being seen, and making it clear, I want that collaboration piece. I want, as a parent, I am asking you to prioritize that, because we will do whatever we can for our parents, truly. And so if you communicate that is a priority for you, then that provider should be responding to that, and facilitating that just from practically, a documentation perspective can be really helpful. And Elizabeth and Natalie, I don't know if in your experience and background, you've come over any other helpful strategies as far as facilitating that.
Yeah, I mean, I want to echo what Maeve said about, like, as much as you as caregivers can be a pivot point in those situations, making sure that we are all informed that the other people are seeing your kids and that we have each other's contact information. That's hugely helpful. Even I've had parents connect us via email, which I always love. That makes things easier and smoother for us. Um, if you are receiving ABA services, oftentimes your BCBA can go out and overlap sessions to do observations with the outside providers that your child might be seeing. And then they can also kind of serve as somebody to coordinate across the disciplines. In private practice or in schools, SLPs and OTs tend to have really, really tight schedules. So it can be difficult for them to maybe come to see what we're doing in our sessions. It can be a little bit easier for us to carve out that time and go see them. And I think that that can be super helpful too. And I've had some really successful relationships where, I have gone to the SLP's practice and observed a session, and then gone to the OT's practice and observed a session, shared my treatment plan with both, and then helped them coordinate sharing their treatment plans, and we've been able to all align that way with kind of like me being the back and forth and carrying messages. So if that's a possibility, I think that could be really, really valuable. But yeah, it also just make sure that they know how important it is to you. Like Maeve said, we really do want to do anything that's valuable to you. And if you're telling us that that's something that you need from us and we haven't made it happen yet, then we will make it a priority. Natalie, I don't know if you have anything else to add to that.
Those are all wonderful pieces of information and very comprehensive. So no, I don't have anything more to add.
What about other questions, Maeve?
Yeah, we have a couple more, so we'll continue on through. So the next question that we have is one that I think Natalie you'd be well positioned to answer, which is what are some of the signs that someone might not be swallowing correctly?
Excellent question. There are many signs, unfortunately, but oftentimes if you have any question about it, definitely make an appointment with your child's pediatrician or primary care provider and discuss it with the doctor. They would be able to first and foremost write an order for a diagnostic test that may be able to tell what might be going on within therapy or ABA. Some signs that providers may be seeing or what you may be seeing at home would be if the child has a history of any consistent chronic upper respiratory infections or that may have lingered or perhaps exacerbated into a pneumonia. Secondly, coughing or choking could be something that you may hear or see if that child's sensory component is working. And it's natural for our body that if something gets headed in the wrong direction, we automatically start a very strong cough reflex or a throat clear. That is something innate that's in us as a way to protect ourselves. What is scary is for children or adults that because of a sensory motor dysfunction, we hear a wet, gurgly voice, like perhaps there's something in their throat lingering on those vocal cords. But what's scary is if they are not trying to clear their throat or cough. So if you are seeing or hearing any of those items, I would definitely make an appointment with your family physician or pediatrician.
Thanks for that, Natalie. Elizabeth, we have one for you. So the question itself says, would ABA therapy help my child from taking off? So I take that to mean that perhaps this child is engaging in some unsafe behaviors. Perhaps they're running away from an adult in an unsafe way. And so I certainly know that this is something that ABA works quite a lot on very successfully. So I'll turn it over to you to describe some strategies that you guys use for that.
Yeah, so that is a pretty serious safety issue right there, and it is one that we encounter pretty frequently. And really, the first thing we're going to do is we're going to do an interview with you as the caregiver, and then we're going to do some observation of your child to figure out why they're taking off. That's always the question we're asking as behavior analysts is, why is this happening? And then how do we use that why to come up with an intervention? So for example, they might be taking off because they want to get to something. You might be in the parking lot of the grocery store and they see one of those little ride things that you put a coin in. I actually don't know if those exist anymore, but there's something fun at the front of the grocery store that they want to get to. They see balloons, something like that. And they are not thinking about the fact that they're in a parking lot full of cars that could be dangerous. They just want to get to the balloon. And so in that situation, I'm going to say, okay, the reason that this child is running away is because they want to access something that is fun to them. To me, that's a communication issue. And I'm going to put into place an intervention to teach that child to ask for what they want before they run away. And that sounds very simplistic. It actually, most of the time, winds up being pretty complex because it's a whole heck of a lot easier most of the time to just run than it is to figure out what words you need to use and how to put them together. And that's where, I'm going to be relying on Natalie too. Probably, we're trying to figure out what is this child's barrier to communication and how are we going to solve that. But there are other reasons that children run too. It could be to escape something. Maybe they don't want to do the thing that you want them to do. But in each situation, we're going to create an intervention that helps them get what they want out of the situation while staying safe. And we're also going to help you as parents figure out ways that you can realistically tackle those things in the environment. And sometimes that means we might go out into the world with you and practice some of those things so we can keep everybody safe. It might mean that we ask you to avoid things for a brief period of time so we can work on them in the center and make sure that the children are safe and responsive before you try it out in the community again. But ultimately, we want to teach your child skills and teach you skills so everybody can be safe. All right, we are actually at time now. You guys had lots of great questions. I hope that you were able to learn a little bit more about each of our disciplines and how they work together. Just to do a very quick summary, we are all focused on helping your children to achieve the skills that they need through each of our various disciplines. And I think as much collaboration as possible that can happen between our disciplines just means we're going to help your children achieve their skills more quickly. And there's another question just quickly about how to get a copy of this recording. So it will be sent out to everybody who registered tomorrow. So you'll be able to see it there. I really appreciate you guys being such active participants. It was a pleasure to get to spend this evening with you. Thanks so much for coming, everybody.
Thank you, everyone.
Thank you.